Okay, thanks everyone. My name is James Petty. I'm from Victorian Alcohol and Drug Association. I'm project officer there. I think it's nice to see everyone in person. Is going to become the most uttered phrase in the world over the next, or at least in Australia over the next 3 months. But I will add to that and say that it is very nice to see you all in person. As Scott said, we are now very lucky to have Associate Professor Dr. Nico Clark speaking on the use of long-acting injectable buprenorphine for the treatment of opioid dependence in a highly marginalised cohort of medically supervised injecting room clients. Associate Professor Clark is the Medical Director of the Medically Supervised Injecting Room and AOD program at North Richmond Community Health. An addiction medicine physician by training, he is head of the Addiction Medicine Service at the Royal Melbourne Hospital and chair of the Victorian and Tasmanian branch of the Chapter of Addiction Medicine with the College of Physicians. His most recent previous role was Clinical Director of Drug and Alcohol Services South Australia. Nico is an experienced clinical researcher focusing on treatment of opioid and alcohol dependence. While based in South Australia, he was the head of the World Health Organization Collaborating Centre on Research in Drug and Alcohol Problems. He also has experience in epidemiology and public health and has worked in a variety of settings from remote Indigenous communities to the World Health Organization in Geneva. Please welcome Dr. Nico Clark.
Thank you. This is my first time presenting something live for a long time. I can't remember the last time I did it. So let me just put on the stopwatch so I can tell how much over time I'm going. So Scott asked me to talk about our use of buprenorphine in the injecting room. So, I mean, I kind of got, there's a few components to that. There's the injecting room itself. There's the way that we provide services for that particular client group that's sometimes different to the way we provide services for people who are better at attending appointments and things like that. Do you want me to, I can, yeah, the microphone's fine. I just didn't want to speak too loudly into it. There's elements of buprenorphine and kind of features of the use of buprenorphine that are both kind of useful and potentially problematic in this population. And then there's the possibilities of the long-acting buprenorphine. So maybe I'll go quickly over the first bit in the buprenorphine bit, and because you're all familiar with the pharmacology of buprenorphine, pretty much, I guess. But I'll just go over that a little bit because it relates a little bit to how we use the buprenorphine. So, and again, similarly, you all know Richmond and that little corner there, which is the kind of epicenter of Victoria's largest heroin market, which sometimes looks nice and peaceful and sometimes not. So the injecting room, if you haven't, but not familiar with it, is that green building there. So the community health centre, which is based, is the green building in the midst of the high rise in Richmond. It's certainly Victoria's largest high rise estate, kind of government housing estate, if not Australia's. And it consists of the kind of high towers that you can see and a bunch of walk-ups nearby. And the community health centre is kind of right in the middle. And it's about 3-minute walk from that corner that I showed you before, just along Lennox Street. And that kind of the epicenter of where overdoses were occurring was that pretty close to that corner of Lennox Street and Victoria Street. And the community health centre is really very close to that. And that was presumably a large part of why it was chosen to be there. In the leading up to this, it was kind of really families who had kind of lost people in the Richmond area. And in one 12-month period, there were 35 people who had died as a result of kind of heroin use in Richmond. And this particular woman lost 2 of her nephews to heroin overdose, and she started a movement, and she kind of, they're the signatures of 35 people from that year, and a bit of a grassroots movement emerged, and then before long they announced this injecting room, and that part you all know. So, you know, and our objectives are to reduce deaths, but to reduce the harms of overdose, to be a gateway to other health services, to reduce reliance on emergency services and hospitals, reduce discarded needles and public injecting, and improve the amenity, which is a bit of a challenge, and to reduce the spread of bloodborne viruses. So in that context, trying to offer drug dependence treatment was certainly in our minds. What we had no idea about was whether anybody would want it. These are a group of people who've presumably chosen not to go on treatment. They've come to an injecting room to use heroin. How would do they want us to offer them treatment? Do they want to be referred to anywhere else? We really didn't have any idea. Kind of fittingly, on the day of the announcement, somebody in fact overdosed within meters of the announcement. So this is the initial injecting room. They all look a little bit the same. There's cubicles for people to inject in a relatively clean environment. There's a lot of cleaning that takes place in between people using it, and they're provided safe injecting equipment. And this was a temporary facility within the community health centre, which had one little room for providing additional support, but it's largely a space for people to come in and use heroin and be resuscitated when they need it, which happened quite a lot, I have to say. And and it was quite an experience to be there when those first people came through and just thought they had never imagined that their community would provide something for them, even if it maybe, they didn't like the fact that they needed to kind of register or kind of abide by the rules. They were kind of really appreciative of the fact that there was a service there for them. So the people, we asked them to volunteer who they were and what they wanted, and some people did. About a third of people did, and they're your typical people who've been using heroin basically for 25 years. On average, the average age of initiation was 16, but we've had people who initiated in primary school right through the spectrum, and about 3/4 male, which is similar to the injecting drug cohort, 15% Aboriginal, very high for a non-Indigenous specific health service, and about a third homeless. 25, 1/4 just released from prison. The vast majority had spent some time in prison, and 1/4 had been out of prison in the last 3 months. So they, even amongst heroin users, and with this is compared to the supermix cohort, these were the most marginalised of heroin users. So in a sense, they were the people that we were hoping to attract. But again, we had no idea whether they would want treatment in this context. But when we looked at their healthcare utilisation at registration, they were often going to emergency departments. They're often being transported by ambulance. They had mental health issues, and they're often taking medication issues. But when we asked them if they wanted treatment, about a third said they were interested in hepatitis treatment, and about 1/4 said they're interested in drug dependence treatment. And that was quite a surprise to us. And we thought, started us thinking, well, how can we best provide that to this population? In terms of what they're using, it was almost exclusively heroin. That's the dark green line at the bottom. This is over the course of the trial so far. And then the lime green is diphenhydramine, which is Unison. So the cohort of people who are basically injecting heroin, sometimes in combination with diphenhydramine, usually without. And very rarely they came in to inject methamphetamine. Well, when I say rarely, it was about between 1% and 5%, so that on any given day we might have between 2 and 15 people injecting methamphetamine, and between we had 80 on the first day, and we've had up to 450 visits in a day over the course of the trial. And if you ask people why they're coming, they say they like the engagement with staff. They feel like it's a safe place. They feel like it's a place where they don't have to hide who they are. They feel like some are concerned about the risk of overdose, others are more concerned, some haven't spoken to anyone for days, and some just don't like being hassled when they're injecting. They don't like having to look over their shoulder to see, are the police going to be there? Are they going to get robbed? It's many people have kind of just come, almost all the time. So we have these people who come once just to check it out, through to people who've been there hundreds, if not more than 1,000 times since it opened. And it really, in the process, you develop a relationship with those people, and we don't hassle them about what they want, but occasionally they say to us, look, I've had enough. I don't want to do this anymore. Can you help me find some kind of treatment? So just in terms of the overall numbers, there's been like more than 250,000 now, but this was as of December 2020 in terms of the visits to the overdose, and more than 4,000 overdoses, more than 4,000 clients, and a whole range of services, some of which are our attempts to provide opiate dependence treatment. Of course, at the same time, there's been this very negative media saying that nobody's going to attend, or that it's not making any impact, or that it's making the situation worse. But there's clear ambulance attendance data showing from earlier on in the trial, saying that there was a reduction in ambulance attendances when naloxone was applied in the area around the injecting room, which means by definition that there's less injecting around there as well. So it's been an interesting journey over the course of the trial. This is just the number of people who visit on a daily basis. There's you can see it rapidly stabilized about 170 visits a day. Then after 12 months, we moved into a new facility, purpose-built, which had twice the capacity, and the numbers went up to over 300 visits a day. And then during the COVID epidemic, there were large changes to the drug market, and we've seen a reduction in numbers to about 200, 220 visits a day on average at the moment. So you can see there when we moved into the new facility, and that's the new facility built out the front there with more injecting booths, but more significantly, it also has this has like an on-site clinic where we can provide a range of services on site. So we can both invite other services to come and work on that site. And so we invited St. V's and Regen, Fitzroy Legal Service, a range of service providers would come on site there. And we would also provide a range of services from GPs from the health centre, bloodborne virus testing, opiate prescribing, sexually transmitted infection, checking some oral healthcare. So in that clinic, because we found, as we talk about, that like many people responded better if we at least initially provided some response on site rather than just giving somebody a phone number or an appointment. So we had a consultation with the people who are using heroin in the area prior to designing this service. And that's clearly what they wanted. They said they wanted a one-stop shop. They wanted to be able to test and treat on the spot, and have for hepatitis and other bloodborne viruses, to have drug dependence treatment, wound care, oral health care, overdose prevention. And they wanted it to be provided by a multidisciplinary team of health professionals and kind of peer workers, basically people who had some experience in their this situation. So they didn't quite get the peer worker thing across the line, but we had people who had an experience often of their own substance use amongst our staff. But we kind of designed a model then, which kind of tried to merge the principles of harm reduction on the one hand with this kind of healthcare service, which was under extreme scrutiny and had to be really low risk on the other hand. And so the injection room just kind of fits in between those two. On the one hand, there's low threshold. Anybody can come without saying who they are or anything. And we try and reduce the barriers to entry. But on the other hand, if we're going to provide healthcare interventions, we need to have a medical record. We need to have safety procedures. It needs to be, we're a fully accredited healthcare service. We had to get accredited in the first week of opening. And so, but we try not to make that a barrier to people coming in, so that they can choose if they want, when they want that kind of greater healthcare service, and provide us with their real name and so on and so forth, if and when they want to. So it was soon after we'd moved into the new facility that there was a new long-acting, the first long-acting buprenorphine emerged. And so we started thinking about whether or not that would make sense for us to use in our clinic. As I mentioned, there was a kind of already a range of health services being provided in that consulting zone. And we really focused on trying to simplify treatments. So if you think about hepatitis, for example, Many people hadn't gotten treatment because it was just too complicated for them. You know, you've got to go to a doctor, go to a blood test. Often they've only done antibodies. You've got to go back to the doctor, get another blood test, then they might send you for a fibre scan. Then they might send you to a specialist and you've got to get the prescription and pay for it. And there's just far too many steps for people who kind of struggle even to make an appointment and remember to get there and be there on time. And our initial referrals, even to the friendly GPs, didn't work. But with the service like this, we had the capacity to design things differently. So for hepatitis, for example, we would offer people a finger prick when they come in the door before they inject. While they're injecting, which often takes about half an hour, we can analyze the sample with a PCR machine, gene expert PCR machine. That takes an hour to get the results. If they finished before then, we can do a fibre scan if on days we've got the capacity to do that. And then basically an hour later, they've got their results and a fibre scan, and we can offer them treatment on the spot. And we've got a friendly pharmacist who will courier down the medication in about 20 minutes. So like when we do it like that, a lot more people are interested in treatment because the barriers have kind of broken down. And so it's not that people don't want treatment, it's just they struggle to get it with their current system. And a little bit the same with oral health care. So oral health in this population is terrible. Most people need fillings, most need teeth removed, and a significant proportion need dentures. Navigating the dental system is even more challenging than navigating the healthcare system. But there are things you can do. You can provide silver fluoride again on the spot. So we had the oral health technicians from the oral health service in the main community health centre come down and kind of provide a basic assessment of people's oral health situation, and then treat any cavities that would normally need fillings with the silver fluoride on spot. So that stains the part of the tooth where the enamel is broken down, but it acts like a filling. It's like a chemical filling for 6 months. And so again, it's painless, quick, on the spot. You build a relationship with the oral health technician, and then they can say, well, why don't you come over and we'll pull out those teeth that aren't really any good for you. And then why don't we get you some dentures? And before COVID, we managed to get 2 of our clients dentures, and both of them got jobs within a week of getting their dentures. They just used to see the kind of look on their face when they could smile and know that people would see that they're kind of fully smiling. And so, what would we think? And these are really, it's just a kind of trauma. It's basically a kind of mechanism of trauma-informed care for this population group. So we're thinking, what do we do for opioid dependence treatment then? People said it's often difficult to access. There are waiting lists. They didn't like the cost of $5 a day. They didn't like attending the pharmacy, generally speaking, and they often miss their appointments, and then they can't get their dose anymore, and then they have to find the GP, but the GP is not taking appointments for 2 weeks, and it all got too difficult for lots of people. So we thought, what can we do about that? So we started off referring to the GPs at North Richmond, but then they became full. They said, we can't treat everybody that you're seeing, it's too many for us. We kind of tried the referral pathways through Direct Line and PAMS and PHN, and again, in our experience, the kind of referrals don't work as well as kind of the face-to-face and initiation. So we started on-site prescribing, and then when the long-acting buprenorphine came along, we thought, well, should we be doing on-site administration, basically? And that's so. Yeah, I'm sure you're familiar with both the long-acting buprenorphine products. So this was the VAADA one, obviously, which is so they offered some potential advantages that you can administer them once a month, more or less. They kind of, if you haven't seen them, they're basically an oily liquid which kind of solidifies when it comes in contact with water, and it kind of forms a ball of wax under the skin, and that wax kind of resolves over. For the monthly injection, a month or sometimes 2 months, sometimes a little bit longer. Very rarely you get a kind of allergic component to it and you have to give somebody an antihistamine. I've never seen a kind of full allergic reaction to it. And in theory, they can become infected. I've never seen that, but it can happen. They are painful injections. I don't know if you've given them, who's given them. Okay, so yeah, they hurt. If you put ice over the skin first, that doesn't hurt. I mean, but I've had a lot of people say, this is going to hurt, and they look at me like I'm pretty tough. And then they go, oh, that really hurt. So you need to, it does really hurt. But the pain only really lasts for about 5-10 minutes, and it kind of settles down within a few minutes of the injection, really. So it's, and these are the places, this is the places where kind of VAADA is recommended to be administered, and Sublocade is recommended to be administered more around in the stomach areas, not the other areas, because the larger doses, larger volume. So we thought, well, what will this work for our population? Was the question, and we didn't. There was quite a lot of debate, I have to say. There were certain people who said, you know, this is a really bad idea. Your people are coming here for a safe space, and you're pushing treatment on them, or you're going to put pressure on them and they won't be able to use, and you'll be blocking the effects of their heroin use. So buprenorphine in the doses that in some of these injections do really block the effects of heroin use, and particularly in the higher doses, the Sublocade 300 and the VAADA 96 128. They really block. Not many people use heroin in the times when they've got therapeutic blood levels of those medications. Is that, you know, what's that going to do for our client group? Will they cope with that? Will they use other substances? So there were a lot of questions, and you know, how we're going to, if we're going to be treating some people and the whole rest of Melbourne wants it, what's going to happen then? We're going to have inundated with people, and how we're going to treat them. So there was quite a lot of anxiety about whether or not it would work. And I'll share a little bit of our experience on how we used it and whether it did work. But some of the way we use it, we need to kind of go back on a little bit on buprenorphine pharmacology. So forgive me if it's like, this is boring, but I'll try and skip to, there's a couple of bits which I think are worth dwelling on. So this is your basic cell wall with kind of opiate receptors on the cell wall. And this is your sedative or opiate, if you like. And it binds to those receptors, and then there's kind of it passes on a mechanism into the cell, and that kind of leads to your opiate effects. If you do that over a long enough period of time, the body becomes tolerant. It reduces the effect that it has to those same opiates over time. And one of the ways that it does that, and it's a bit of a simplification, is it reduces the number of receptors on the cell wall. So you might start off with lots of receptors, and then over time, you've got less receptors. And it's just a way of kind of not, you know, the body seems to have developed means of avoiding death through sedative overdose. And don't know how, but obviously we've been taking sedatives for a long time, and that's one of the mechanisms. The other one is that it kind of produces its own endogenous stimulants, kind of circulating adrenaline, noradrenaline. And then over time, these kind of balance each other out. You've got the positive effect of the stimulants, you've got some sedative effect, but less than you might have had if you weren't tolerant. And this kind of combination means you can take an enormous dose of a sedative on a regular basis and be kind of standing up and walking and talking and doing what you need to purchase heroin. And but if you suddenly stop that, you'll feel horrible, largely due to the fact you've got all these stimulants there. So you get this kind of stimulant excess for a period of time. And it takes about a week for that to resolve. It's like the period of a detox, is the time it takes for your body to start kind of both kind of reducing the number of, the kind of down-regulating that stimulant effect, and kind of up-regulating your sedative receptors. And of course, you can help that process by giving something like buprenorphine to help manage the opioid withdrawal. Or you can use something which targets the stimulants, such as clonidine, and help dampen down that effect. So what's the difference between opioids then? So heroin and this is a kind of another cell wall with a bunch of heroin receptors, opiate receptors, your heroin binds to it, and you get a downstream effect. Similarly, methadone binds, you get the downstream effect, and longer acting opioids tend to produce more tolerance. And so you might start off with lots of receptors and then
you'll end up with fewer receptors, and that's kind of your tolerant state in combination with your endogenous stimulants there. So that's somebody who's tolerant on methadone or higher doses of heroin. Now, and this blocks the effects of heroin largely because there aren't so many available opiate receptors anymore. You've kind of downregulated so much that there's not much free. If they take higher doses, they can displace the methadone, but that doesn't make any difference because the methadone was already producing an opiate effect, so one for the other. So but buprenorphine blocks in a slightly different way. It kind of binds to lots of receptors and produces a kind of minimal effect. But there's still not many receptors left over. So that's because buprenorphine is a partial agonist, obviously. So it binds to the receptors and only partially turns them on. So you might have lots of receptors occupied, but you've only got a similar effect as if you're kind of a stronger opioid only binding to a few receptors, but there's still not many receptors available. So that's your tolerant state with buprenorphine. And we know from some, and there's some clever imaging of the brain at the time, that this is effect of a 16 milligram buprenorphine dose. That kind of the vast majority of opiate receptors in the brain are occupied. If you look at this graph towards the 24-hour period, so that's kind of when less are occupied, but if you look at that solid black line about 1 hour after the 16 milligram is administered, you get the peak effects, and you've got really there's not many opiate receptors left in the brain that heroin or something could bind to. And with higher doses of buprenorphine, you get even higher receptor occupancy. You get almost complete receptor occupancy, and people still breathing because of the fact that buprenorphine is this partial agonist and doesn't produce much additional effect when you get additional doses, really. So what does that do then in our situation when, if there's in the presence of if let's say somebody's taking methadone and then along comes buprenorphine, the buprenorphine can displace the methadone because it binds more tightly, it produces less effect. So you've got this kind of situation of opiate withdrawal. So buprenorphine can make people sick, and almost everybody we spoke to said, "Oh, I don't like that Suboxone; it makes me sick." I've had, and lots of people have had experiences of precipitated withdrawal. I think about 10% of inductions result in precipitated withdrawal, even with sublingual tablets to one extent or another. So, who's going to get withdrawal is a large part of the discussions we have with people, and it depends on the tolerance that people have. How many receptors they kind of cut back. The opioid receptor occupancy, so the dose, the buprenorphine dose that you give people, the previous opiate receptor affinity and the time in between. So there's a lot of factors which affect whether or not somebody's going to get withdrawal. If we, in treatment with methadone, lots of people would get withdrawal if you give them buprenorphine, particularly on higher methadone doses, when the time from methadone to buprenorphine is shorter, and when you use a buprenorphine dose of 4 milligrams or more. So 4 milligrams is enough to induce precipitated withdrawal. Okay, if you can do it. Oh, I thought I had 20 minutes. Oh, that's no good. All right, I'll have to be quick. So you can get withdrawal with 10 milligrams, with 2 or 4 milligrams. So when do you get precipitated withdrawal with heroin? About 10% of the time, open in people who are really tolerant, large amounts of heroin use. And the time between heroin and buprenorphine is less than 12 hours. Precipitated withdrawal, it looks like opiate withdrawal lasts about a day. But there's another kind of withdrawal that people can get, is if they're just really tolerant to opioids, there's no dose of buprenorphine that can match that. And then they get withdrawal, and that lasts about a week. But it's not like an intense precipitated withdrawal that comes on an hour after the buprenorphine dose. They just don't feel comfortable after a day or two. So that's a different scenario. So precipitated withdrawal comes on after about an hour, goes away after a day or two, and you can treat it with normal options. I prefer to use clonidine. That this kind of people are really high tolerance, so it just takes them a week for them to settle on buprenorphine, and that's the time it takes for them to downregulate their receptors again. I'll skip over the kind of the further slides and get into the treatment of what we're doing. So, so the with these the main advance of the injectables, you get similar peak doses. So the top of the line at the peak doses, you get similar doses, a bit more sublocated. The real benefit of the injectables is you get much higher trough doses. So, if you take, we saw in that previous slide, 24 hours after the 16 milligram dose, the levels had gone down to a much lower level. The advantage with the injectables is that the trough levels remain high, so there isn't this period when people can inject. People like them overall in the studies that they've done. They work as well as, they work as well as sublingual buprenorphine in the research that conducted by trials, or much better than placebo in case of some other trials. Their recommended use is to start with the sublingual treatment for a week, or now with VAADA to start with a low dose of VAADA, either 8 or 16 milligram weekly, and then to kind of stabilize on that, and then to go to higher doses. Our experience is a little bit different to that. We have been using these medications in an off-label way. Now, it's not illegal to use medications in an off-label way, although it does make some of our staff nervous. But obviously you take a degree of risk when you do that as a health service. So your health service needs to be aware that if you're considering use in an off-label way, and that it needs to have decided that the use justifies the risk. But this is the kind of recommended treatment. This is a little bit old, that slide. It doesn't include the fact that they're recommending direct induction on low doses. And then for Sublocade, this is a kind of, obviously it looks a little bit different. It's slightly higher volume. It's 1.5 mils for the 300 milligram dose and 0.5 mil for the 100. And the Sublocade's recommended initiation 300, and then you switch to the 100 dose. So it's kind of it's a slightly different approach than kind of VAADA, which gives recommendations a little bit more like methadone to kind of start slowly and titrate. So, I mean, our experience with buprenorphine is if somebody is tolerant, the dose that you give them will just will influence how long it lasts for and how much it blocks heroin, but they won't really feel very different with it. So our model then, we assess the tolerance, we assess other sedative drug use, we assess treatment goals, we assess recent opioid use, we assess how much they are prepared or not prepared to get precipitated withdrawal symptoms, and look at their current level of withdrawal and intoxication. Then we have an informed discussion with people. Many of our clients would say, I'm not coming here every day for a week. My so-and-so's on this medication, he's done really well. Are you going to give it to me or not? I'm here. I'm not coming back tomorrow. And in that context, we thought, well, let's give it a try. And people are informed about the risks and benefits. There's a real possibility that it will work well for that person. And so we have done a lot of direct inductions onto the weekly and monthly doses of both these medications in full informed consent of the patients. We have the capacity to dose with sublingual medication on site for a week or two if people are able to do that. We often, for people who are at least moderate dependents, we're quite comfortable to use quite high doses initially if people are happy to have their opiate receptors occupied and to block the effect of heroin use. So we say, do you want to stop using, or are you just trying to manage it a little bit? And most people tell us they want to stop. And we were really surprised about that. They said, I've been doing this for 20 years. I'm just tired of it. And but for them, the process of going through treatment before hadn't worked out, and they just didn't want to do that again. But many people said, "Oh, my mate's on this medication, and they say it's great. What do you think?" So we would often support it, but some people did get withdrawal symptoms, and we would support them through that. We'd give them, typically clonidine is what I would prefer to use in that instance. Okay, so and then in our ongoing treatment, we'll often, again, do some things which are not on the product label. We'll often give the medication, we'll give top-up doses if people don't feel like fully comfortable, and we'll often give them more frequent dosing if they feel like it's wearing off, particularly Buvidal. Sometimes people feel like it's wearing off between doses. And with Sublocade and even often Buvidal, people will come like 3 months later and say, I'm ready here for my next dose. And you'll say, well, initially we say, look, I'm not sure that you're tolerant anymore, and we don't know if it's gonna knock you out. But what we saw is that there's huge variability in how long they last, and people don't get precipitated withdrawal. Let's say they started using heroin again and they come in 2 months after their last dose. In that context, there's enough buprenorphine in their system, they don't get precipitated withdrawal. So we just re-administer the injection and they're fine. So what are the outcomes of this approach? So we did an analysis of the first 41, showing we've treated, I think, more than 350 people with since we started now. And we've got an analysis of the first 41 and then the first 12 months. That 60, you see the retention on the right there was pretty good for this population. And that the kind of average person reduced from 10 visits a month to no visits a month in the time after the first injection. And there's minimal other additional substance use. You can actually see each of the people in that study. You can see according to the duration of treatment they've had. There was a group in this study. It was 5 people who had the weekly and then decided it wasn't for them. And often the weekly is, people don't feel great until the second week. And so I think people who start on the weekly are more likely to decide they want to try, that's not going to be for them. But, a lot of people said it's the best treatment experience I've ever had. I didn't feel like using hair anymore. It was a life-changing experience. And I'll just share a couple of minutes, if I can, some examples of our cohort of the first 12 months of treatment. So this was 129 people in this analysis. Not quite as hardcore as our average person. So the average age of initiation is 19, slightly less Indigenous people, but nonetheless, because a lot of people, there's friends that come along and other people said, I want to come and get buprenorphine, because for a large part, it wasn't easily available elsewhere. So, and we didn't want to say no to people. So this is a mixture of the injecting room people and their other people they brought along. But we saw again, there was a big reduction, and this is not the median reduction, this is a mean number of visits, so it's a slightly different, but we saw a big reduction in the visits to the injecting room after the long-acting injectable. So it's the first month after, and then 12 months after, that's continued to decline. And that's a kind of spaghetti plot saying with each of those people showing that, some people had massive reductions, some people had kind of modest reductions in their heroin use, and that's just looking at the more severe ones. So we asked people about their heroin use in terms of their the number of days heroin use in the last 28 days. Again, we saw a big reduction. And on average, we gave people 2 weekly injections and 5 monthly injections in that 12 months period after they initiated a long-acting buprenorphine, which gives a retention in treatment for this cohort that's kind of comparable to the kind of what you might see. In fact, comparable to what you might see in many clinical trials of kind of less severe cohorts. And we don't know from this analysis whether they went on to get treatment somewhere else. This is just what we provided them. So, but we did see a pattern that people would often stop using heroin for a few months, and then they would think, I don't need this anymore. They would wear off, they'd start using heroin, and they'd come back again. There was no across the board increase in other substance use. About 10% of people would, though, switch to methamphetamine or alcohol use. And there was big reductions in injecting and improvements overall in their quality of life. But perhaps the most outstanding thing was how much this population thought that this was a better treatment than methadone and Suboxone. So I've got some little vignettes, but we probably don't have time for them, given that I'm out of time. We could just stop and have a couple of questions, but just to say, look, it really does increase treatment options. One setting in which we used, another setting in which we've used a long-acting injectable buprenorphine is in a homeless hotel situation. So this is the IBIS Hotel in King Street, and we did a pilot project in that we set up a clinic in that corridor there behind us, and put kind of flyers under people's doors and said, would they like needles or naloxone or hepatitis testing and or drug dependence treatment, and we typically had somebody come down and say, yeah, I'll do that, and we started in that little pilot. We started 4. The first one is that was the moment that he's kind of given up his heroin. He's got a nice girlfriend and a flat in Elwood, and he's kind of, he's happy as Larry. And the other 3 are kind of still engaged in treatment from that time, but with, so it's like it increases our possibilities of use in ways that we haven't perhaps considered before. And just to acknowledge that there's been other people involved in providing this treatment at the injector room and in the analysis. All right. Thank you very much.
Thanks, Nico. Yeah, that was really, really fascinating and important as well. I think when you talked about the dentures and them getting jobs, I got quite choked up, and I just think it's so important. We do have time for a couple of questions. The first one that's come through online, which is always the first question, is, are you willing to share the slides afterwards?
I think so. I think they're all available online anyway, but I'll share a version, if not the whole thing.
Yeah, that'd be great, and VAADA will sort that out and get that available. Are there any questions? Yeah, Tom.
Do you have any numbers on number of people who you would start with sublingual Suboxone versus those who use straight injection?
We've started the majority on straight to injection. We always tell people that it's recommended that they take sublingual.
Any other questions? Well, I have one, and I'm kind of sorry to ask it because it's a bit unpleasant, but I have heard or read about an identified risk around long-acting injectable buprenorphine, that there's a risk of, I can't remember the word for it, but diversion, sorry, basically involving either the client or someone else sort of removing the injection. Have you heard?
No, I haven't heard anything about that, and we haven't seen anybody try and do that. Pretty difficult because it's no longer a liquid form; it's really a waxy ball. I think maybe Suzanne will know, so she should know if there's been experience, but I haven't seen. It's the least divertible form of opiate pharmacotherapy, I think.
Yeah, I had read about it as a risk and no confirmed cases, but I was just curious. Scott, what?
No, I was going to say no. Suboxone's been out in the US, I think, 3.5 years, and there's absolutely no cases of anybody cutting it out. Even in the correctional facilities, no one's been reporting it. And then they'd have to be a pretty good chemist to be able to separate it from the solid itself.
Oh, great to hear.
Probably not.
Were there any other questions for Nico?
I do have one question from the Zoom chat. And there's a question of whether there's a preference in terms of Buvidal or Sublocade.
Look, I think there are different doses, obviously, with Buvidal and Sublocade. Sublocade offers a higher dose than Buvidal does. So, like, we always ask everybody what they want. Do you want to stop using heroin, or do you want just to help manage it? We don't want, it can be a risk for people to kind of suddenly not be able to get the effect from heroin that they were experiencing. And so if people don't want that, then you can get a range of lower doses with Buvidal than you have necessarily with the Sublocade. If you're wanting the highest dose, longest treatment, there's no doubt Sublocade has a higher dose and longer duration of action. We see people coming in, people don't feel, and just to mention, they wear off gradually, but particularly the Sublocade wears off very gradually. And many people, you don't need to kind of titrate the dose down. They just titrate themselves over time. So we've started, for example, people on Sublocade 300 in hospital. They've gone back to their bush block in Tasmania and never taken any other opioid. It's just kind of worn off gradually. They didn't need any withdrawal medication. They kind of felt a little bit of withdrawal. So, and certainly the longer acting ones, I think, can withdraw off a bit longer. And so we just encourage people to stay on the high dose till they're ready to stop, sort out their life, and then just stop. And that gradual reduction, I think you can get more with Sublocade.
Thank you.
All right, thanks everyone. Thank you, Nico. Now it is, yes. So it is now my very great pleasure to say that it's lunchtime. And that's it. Thanks everyone. And we'll be back here at 1:20.